Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Velody. And boy, today we've got a really interesting and great podcast for you. We, as you know, take a lot of emails from family members and folks who have questions for us to address on the podcast. And today, for the first time in our history of the podcast, the person who wrote me the email also happens to be a PhD and an expert in many ways as we talk about aspects related to pain sensation and perhaps even speech issues in people with Down syndrome. And so Meredith Whittaker is on with us today. And Dr. Whittaker, thank you so much for joining us today, as we do with all of our guests. If you wouldn't mind telling us a little bit about who you are, what you do, why you love people with Down syndrome, and then we'll just get right into it.
Fantastic. Thank you so much for having me on. I'm really excited to be here today because I really love the podcast. I discovered it maybe about a year ago, and I've been digging into the archive and listening and really enjoying everything. Yeah,
I love it.
So as you said, my name is Meredith. I have a PhD in immunology and microbial pathogenesis from Weill Cornell Medicine in New York City, and I'm based in New Jersey. I studied tuberculosis for my degree, and so listeners might be thinking, what does she have to do with Down syndrome? But my older brother has Down syndrome. He also is on the autism spectrum and has a whole host of epilepsy, dysphagia, some other things going on. But the most important thing about him is he's an absolute sweetheart. He loves music. He loves swimming. He's really very special to our family. And I'm co-guardian of him with my dad ever since my mom passed away a couple of years ago. So in the past, I've always been kind of inspired to science and medicine because of him. And actually, when I started my scientific training, I thought I would go into studying Down syndrome at the bench. And I did my undergraduate research in Alzheimer's and learning and memory, something that was sort of kind of tangential to Down syndrome, as I'm sure a lot of listeners are aware. People with Down syndrome, as they age, can have sort of a higher risk of Alzheimer's. And as much as I enjoyed that research, I just found that it hit a little too close to home.
Yeah.
I have kind of a big bleeding heart, and it's like, you know what? I'm also interested in microbiology. I'm also interested in the immune system. So I dove into that for my PhD. And now I work as a medical writer, which is a role in which I get to help kind of translate scientific and medical findings to a variety of different audiences. Primarily, I'm helping communicate to physicians or healthcare providers when new clinical trial results come out, things like that. But I do also get to do some kind of patient engagement work. And I feel like this love of science communication that I have is very much informed by the experience with my brother over the years, speaking to his doctors, learning more about him. I mean, even when I was a kid, I don't know, I know you're also a sibling, so maybe you also had, books that explain what chromosomes are when you're like 8. It was called My Sister is Special. And that book really stuck with me. So these kind of being able to make science accessible to everyone is something I really care about. And so that's a big part of who I am and why I care about that.
That's so great. And as you know, as someone who's been listening to the podcast, we love to have siblings on, as you might imagine. And so it's so great to have you on with us today and to be able to share your knowledge. I mean, I think, when you had reached out, you had shared a story, which I'm going to ask you to share here in a little bit, about an issue, a medical issue that had come up with your brother recently, and how speech issues played such a huge role in it. And as we've had on the podcast, right, we've had Libby Cuman, we've had Betsy Gilbert, we've had folks who know speech issues in Down syndrome really well. And they've talked about how when people are nonverbal or have a hard time expressing their speech, whether it's, developmental delays waiting for speech to come in, or speech apraxia, or, completely, nonverbal or stuttering or whatever it is, that inability perhaps or challenges with expressing thoughts can make it very difficult in a medical field. I can tell you, when we have patients who are nonverbal in the hospital or in the clinic, a lot of the times it's that careful exam, it's that listening to the caretakers and really taking their concerns seriously, because obviously they know their child, their loved one, much more than we do. And hearing their concerns is, I think, to me, has been the most important thing. But why don't you do this, if you don't mind, as much as you feel comfortable, share about that recent experience you had with your brother in an ER recently, if you don't mind.
Yeah, absolutely. And I should also mention my brother's name is Billy.
Ah.
um, Bill, sometimes. But and
Yeah.
he actually just had a birthday. He just turned 36. So
Yay.
this gives you a sense of the age range we're in, and also he is basically nonverbal. I mean, he has a few words. He can, and for those who know him well, he can get his point across. So when he's hungry, he might go pizza, pizza. He does a lot of repeating, and some kind of just like babble, I guess.
Mhm.
Sounds that aren't really words. But he can say grandma. He can say grandpa. Occasionally, he'll call me baby. That was when I was introduced as this is the baby. That kind of
Wow.
stuck, which is really amazing. So that's kind of where he's not really able to tell you, hey, I fell, or this hurts. He doesn't have the intellectual capacity to point at something that hurts. So whenever something is going on, it is a real puzzle to figure out what's the
Mhm.
situation. uh, and I think part of why I was inspired to reach out to you is that this is now the second time where we've had some sort of emergency situation where it was ultimately one of us in the family who figured out what was happening, um, rather than someone in the ER. And
Mhm.
it's no judgment on the folks in the ER. I know they're doing the best they can, often with limited resources. And this time around, it's a pandemic also. so
Yes.
so there's that. Um, so anyway, so my brother lives in a group home, which we are very fortunate to have a really great relationship with them, and he lives close by. It's very easy to visit him. And they called us to let us know that he had been walking from the bedroom to the bathroom when he kind of got sick halfway there, and he fell, and then he wouldn't stand back up, and no one could figure out why he wouldn't stand back up. And normally for him, if he's not in the mood to like go with whatever the activity is, he might stay sitting down. So, but this was unusual for him to like really resist so much. So they called 911. They take him to the hospital, um, and all his vitals were good. He never like threw up or had diarrhea again. And so we're there with him, and he's sitting there looking pretty normal. He's getting IV fluids, but he's still like, if we try to get him out of the bed to go to the restroom, he just like couldn't stand. Or I mean, and this is one of the things where with the limited language, it's hard to tell if he couldn't stand or wouldn't stand.
Yeah.
Is this an I can't or I won't situation? Um, and so, I mean, this all started around 8 a.m. And then finally around like 3 o'clock or so, my brother just happened to pull his socks off. And my dad goes, do you think his right foot looks a little swollen? And then all of a sudden it was like, ding, ding, ding. What's a
Yeah.
reason people don't stand is if something's broken and
Yeah.
they had very carefully inspected his legs, kind of like making sure that he had full range of motion, and the folks in the ER had definitely kind of just like very gently tapped his feet, and
Mhm.
he never flinched. Like he never his like demeanor was still very much his normal self, and if anything, like we haven't seen him much because of the pandemic guidelines with the group home, so I think he was actually like in a good mood, like he was happy to see us.
Yeah.
And he really responds well to music. I think that's something that a lot of people with Down syndrome and autism spectrum disorder, like we get through a lot of doctor's appointments singing, and so we've been just hanging out in the ER singing, but then all of a sudden he pulled his socks off, and they went ahead and did an X-ray, and it turned out he had broken his second, third, fourth metatarsal.
Wow.
Um, Crazy, right? And
Yeah.
I mean, we're pretty sure that what happened is just when he went down, when he got sick halfway down the hall, he just got really unlucky and landed on his foot
Oh.
bad. Just and something that was interesting too is I learned kind of after the fact that the seizure medications that he's been on for years, a side effect of them can be some bone density concerns, and so that's something that I now have on my radar. Is like, okay,
Yeah.
we got to be mindful of these things. So the good news is that he didn't need a cast. He just needed like an orthotic shoe. And actually, just yesterday he had a follow up, and it's on track with healing. So he's in good shape, and he's able
Yeah.
to move. So like the story ends well, and we were very relieved in the end that it was something so like simple. Like we're sitting there, like, what does he have an issue with his nerves? We're just sitting there like, what could this be?
Yeah.
Um, so that was our most recent incident where it was just like, is there anything that could be improved in the ER as far as
Yeah.
like helping families troubleshoot what's going on? Yeah, that was kind of.
Yeah, and what you're describing is something that those of us who work in Down syndrome centers like I do, we talk about this so frequently. And in addition to just, talking about the speech issues as we've addressed today, there's also this seemingly understanding amongst all of us that people with Down syndrome have a different way of either processing their pain or expressing their pain when they feel it. And these challenges can be super difficult. Like I remember when I first started at the center, I had a 15 or a 16-year-old, and it was the first time I had met them, and they had come in because of concerns for early onset dementia. Now, as you know, a 15 or 16-year-old, that's unheard of
That's
to have
very early.
Alzheimer's
Yeah.
dementia at that age. And as it turns out, he was belching more than usual and grabbing at his chest more than usual. And, we did some routine labs and whatnot, but I just started him on acid suppression. And in a few weeks, the family called me and said, his dementia's gone. And I said, because
Wow.
it wasn't dementia. And it was
Yeah.
pain that he wasn't able to express. And we've had kids who have come in for belly pain and fever and being treated as if it's a stomach flu. And there's no exam findings to be any other concern. And sure enough, we find out later that their appendix perforated because they had appendicitis.
Wow.
And it just was missed for so long. And missed fractures like you're talking about, even hip dislocations where the kids just don't show any signs of having severe pain like you would expect. And yet they do have these significant issues that need to be addressed. So I was wondering if you wouldn't mind just kind of sharing a little bit of what you've discovered or found about what research has shown in this field.
Yeah.
Go ahead, Meredith, tell us.
Absolutely. I mean, I imagine there are many siblings who, when something's going wrong and you feel like there's nothing you can do, you turn to Google, you turn to WebMD, whatever. And then I have in my arsenal, PubMed,
Yes.
all of the medical things that I've learned in my education. So I turn to the literature, and it's really fascinating to see what's out there, and I find a lot of comfort in knowing that I'm not alone in facing these kind of concerns. So there's a really nice review on this if people listening want to read. It's by McGuire et al., and it's called Pain Perception in People with Down Syndrome, a synthesis of clinical and experimental research. And this was published in 2015. And they compile a lot of really nice studies. And sort of the punchline of it all is that people with Down syndrome do feel pain, but they may have kind of a delayed reaction to it, or there's delays in both sensing it and also delays in communicating it.
Okay.
So maybe, to use the example of my own family, maybe Billy wasn't in pain for much of our visit, but then maybe when his foot did start hurting, that's when he yanked his sock off, right? And so I find a number of people, when I was recounting our story to them, they said, oh, well, people with Down syndrome don't feel pain, so don't be too worried. But I think it's wrong to assume, I mean, I think, and actually this review, or maybe it was one of the other resources I found, suggested exactly what we ended up doing, of if there's a possibility of pain, to give some pain medication,
Yes.
even if the person can't say, hey, I need some Tylenol. So that's exactly what, with my brother, what happened was, we know, even after we put the boot on him, he was still kind of hesitant to stand up. And, since we had the all clear from the orthopedist that, he can bear weight. So that's when we said, okay, we need to get him some Motrin, or, that's when he ended up, they gave him Motrin. They tried, getting him to stand up a couple hours later, and then he would, and, it's just one of these things where it's like so simple after the fact. It's like, of course he didn't want to stand. His foot hurt.
Yeah.
And so by make understanding what was likely going on and then giving some of that preventative pain medication, I think really helped.
Yeah.
Um, yeah, and so again, just getting back to the review, one of the things that they mentioned, like right from the get-go, is that a lot of parents of children with Down syndrome have difficulty, locating the pain or guessing if there's pain. So, if it's difficult for the parents and
Yeah.
caregivers, it's probably going to be that much harder for the physicians too. So I think that it's really good to be able to discuss this and kind of bring it up as something where like we all need to work together as a team to kind of troubleshoot.
Yeah.
Yeah. And
And I think that the point that you made about giving the pain medication, I think it's so important, right? Because we know that in medicine, there are a lot of inherent biases that we bring in. And we've learned a lot over the last year in doing reviews, looking at how physicians interpret pain from people of different races, that folks who happen to be Black may not get pain medications for the exact same issues that other folks might get pain medications for. And I think we see the same thing within folks in the developmental disability community, where there's an assumption that they don't feel pain, which I think is so detrimental to providing adequate care and being human, with another person. So I really appreciate that article that you brought up brings up that information as well.
Yeah, definitely.
Yeah.
And you raise exactly a point of, as I was digging into the literature on pain and nonverbal patients and things like that, there are so many reasons that you might have a nonverbal patient walk into your ER. It could be that they speak a different language than the care providers. Maybe the patient is intubated, or it seems like a lot of like pediatric patients may not be able to communicate their pain as well, things like that. So yeah, this is a bigger issue than just folks with Down syndrome or folks with autism. And one thing also that I read, so I guess part of, I think, that assumption that people with Down syndrome don't have pain is based on this slower time to report it. And there's a couple studies where they've measured pain, and if it was a pain test that relied on how quickly someone reacted, then that's where you got this result that said that the person with Down syndrome had lesser pain. But if you used a type of test that didn't rely on response time, then you did correctly measure their pain. So there's sort of a scientific basis here for the fact that yes, people with Down syndrome can experience pain, and it's up to those around them to think outside the box with measuring it. And what was kind of neat to see is there are a number of like pain scales out there. So I know I've seen the one where it's like faces, and it's like, how are you feeling? And that it seems like people with Down syndrome who do have, more ability to communicate than my brother, let's say, they can use those kind of scales quite well. But if you try to say, from 1 to 10, what number would it be? That folks with Down syndrome may struggle with something like that. And so it's up to us to think outside the box. And then in the absence of some kind of pain scale that the person responds to, there are pain scales where the physician can look for things kind of like how you were describing the patient you saw who was clutching his chest and that ended up being, if the person is touching an area that may be in pain, that's kind of a really good signal. And just looking out for changes in their personality, or like when I was describing my brother, yes, it's normal for him to not want to get up right away, but it's not normal for him to persist doing that for that long. Right. So cluing into what's normal about the individual and what's not is really important.
Yeah. And I think it can sometimes be intimidating for a family to come in with their loved one. They go into a hospital setting and, well, the doctor said, there's nothing wrong. And so that's that. But if you know in your heart that there's something dramatically different in your loved one, you know them better than any medical provider is going to know. And I guess from a physician's perspective, my hope would be that families would feel comfortable advocating more strongly for their loved ones to say, no, it's not right. Something just doesn't fit. And not to just blow it off as, something viral or whatever, but to recognize that this is definitely different, and really encouraging those medical providers to dig a little deeper, perhaps, for finding the cause of the change in behavior, or change in their activities and things like that.
Exactly. You're reminding me of, there's a book that I read recently. It's a relatively old book, but it's called How Doctors Think by Jerome Grootman. And I really found that book very valuable. And one of the things they kind of talk about is that there's a lot of common pitfalls you can fall into when you're making a diagnosis, and that when patients or their caregivers ask a lot of questions, then it can help like jog the physician out of what their maybe normal pitfalls might be, or something like that. So like in the case of my brother, they kept saying to us, well, he may just be weak. So, he was sick this morning. Maybe he just needs more fluids and to rest, which is a very reasonable thing to say, right? But, at some point in the day, we were just asking questions like, well, is it normal to take this long to recover from diarrhea when he's had however many bags of IV? Just to kind of push them a little to think, what else could it be? And that in the book they talk about that, saying, well, what organs are near where he keeps clutching, right? Or what else could it be? Like, I think that that kind of thought process is really helpful for a nonverbal patient, where you have to kind of speak for them.
Well, great. I thank you so much for sharing this information. Is there anything else that you came across, or anything else you wanted to share with us before we kind of come to a close? I think this has been super helpful for our families.
Yeah, I think these were kind of the main things I wanted to discuss. I mean, and I know it was also interesting for me. I read there's the medical care of adults with Down syndrome clinical guideline, which is really fantastic. And I printed out the checklist that they make for you.
Yes.
There's a lot of good stuff on there, but even that, I don't think they covered, nonverbal communication, things like that. So I think this is the sort of thing that, as we know, Down syndrome itself is a spectrum. Autism has spectrum right in the name.
Right.
And so, when we consider patients, so many people with Down syndrome can, to some degree, communicate what's going on, but there are plenty of us who are in kind of our situation of, we try to speak Billy's language as much as we can. And so I really appreciate you giving this topic, a spotlight on the podcast. And and I know that some similar topics have been raised in your past episodes on autism. And so I think that probably for folks with that dual diagnosis, this topic will resonate a lot.
Yes, definitely. And those healthcare guidelines for adults, that was the first edition that had really ever come out for adults. And we did a podcast with Dr. Bulova, one of the authors, and one of the things that and one of the things that he mentioned was there were so many things that they needed to cover, but you couldn't cover all of it in the first set. But I bet you in the next set of guidelines, as they expand what they're able to cover, I think we'll start to see some of these topics coming up that are so important.
It's so good. It's like, it really makes me happy to see these efforts kind of blossoming. My brother and I grew up in the early 90s, where there was, some community through his school or things like that, but it's amazing to see the way with podcasts, with Instagram, Facebook, just the community is growing, the awareness is growing. And so it's really
that's great. Well, thank you so much for being on the podcast today and for reaching out all those weeks ago. And I really do appreciate you sharing your knowledge with us today and your stories with us today as well. For our listeners, I hope you enjoyed this podcast as much as I did. I think there's a lot of really great take-home points that we can find here. And also, I think as we advocate for our loved ones with Down syndrome, not forgetting simple things like treat pain and see whether there's an improvement in their symptoms, and advocating in that ER room or in your doctor's office for your loved one. I think these are some really great and important things, because we all know our loved ones with Down syndrome more than anyone else could. But until next time, I ask you, just keep sharing your topics. This is how the podcast is going to be moving forward, as we address new topics that really are going to be more what our community wants to know about. So send us an email at Down Syndrome Center at chp.edu. Let us know what you'd like to cover. Maybe there's a topic you want an update on. This podcast has been out for a long time now. There may be some topics that you'd like us to cover again, and we'd be happy to do that. So yeah, just send us a message, and we'll be glad to do that. But until next time, bye-bye.